overly impressed. We're right here with my son, Alexander, Saturday morning, actually in Sydney Saturday morning. It's been all fantastic. We almost feel Australia is fake. There's something behind everything being so organized, people being so kind. I've never visited a place as nice as Australia, so I don't think I'm going back. You're stuck with me. All right, there's not much to follow Chandra's presentation. I'm going to try in my talk go into some of the specifics of the treatment. So let's assume we're not here, we're not having a good time, and we're in the OR. How many of you are currently doing laser surgery? Laser refractive surgery? Okay, so about half of you. So half of you don't do laser refractive surgery. Which is interesting because in the meeting today there was a discussion about how lens-based surgery may in the future replace cornea-based refractive surgery. And that's definitely an argument. We've seen a lot of change in the refractive arena. And me, myself, I don't do laser vision correction for patients over 8-9 diopters usually. We go to lens-based surgery, and that's a new paradigm over the last 5 years internationally. Although we know lasers have approval, FDA, CE mark, I'm assuming it's similar in Australia, for myopia up to 14 diopters. So I don't think anybody does -12s or -13s. So let's see what I have for you today. These are my financial disclosures, and I do consult for Alcon. This is I'm sure you've seen that. It was very novel for us flying over Sydney. This is my background. My background is mainly the background of a cornea surgeon. So a lot of the things that I'll be sharing with you today is a perspective of starting to use laser technology in order to treat sick eyes. And this is basically how all this concept of customized treatments began. We will all agree that today, all laser platforms available out there can give spectacle independence at a very high level. We're probably one of the few specialties that can really offer a change in the quality of everyday life that people have, especially those who wear contact lenses, and a much better risk profile than wearing contact lenses. We know that the current literature supports that the difference between somebody having laser vision correction or wearing contact lenses is similar to that of flying or driving. And it's a very similar, in my experience, decision for the patient as well. Who wants to fly in this room? Who wants to drive? Everybody wants to drive because we feel safer. We have our hands on the wheel. We feel we're in control. But there's no doubt that flying is safer. So we're in an era that all laser platforms can offer very safe, very good spectacle independence. So the things we are talking about today are beyond this point. For those of you who are, I see a lot of young faces among us today, those of you who are at the beginning of your career, it is given that today you can make someone very happy and spectacle independent with laser vision correction. What we'll be discussing today, which I find very interesting, is that technology has reached the point to go past spectacle independence and make people see even better than they ever saw in their lives. And this carries on for the rest of their life, even when they become pseudophakic with things that we know today, etc. So let me go and try and validate some of the promises I made to you. And this really shows a paradigm change. Of those of you who've done laser surgery for many years, it would have been impossible to have contrast-sensitivity pre-op and red here improve post-op. The rule, and I'm old enough to have done my first laser procedure in '95. So the rule was that we were scared of getting contrast-sensitivity in patients post-op because the data was far worse post-op than pre-op. So this is the big difference of modern lasers. We're not making contrast-sensitivity worse. Why is contrast-sensitivity so important? It's important because those of you in the back of the room are using spatial frequencies that are at this level here. I'm using this spatial frequency because I have the spotlight in my face. So this is the part that we spend half of our living life, driving, watching TV. We go to the mesopic range if we turn off the lights in the room, and if we're driving at night, we're at the scotopic range. So this is a very important part of our everyday life, and lasers have evolved to be able to address this and improve contrastivity. So we're not talking about spectacle dependence here. We're talking about being able to see better. And this is very difficult to measure, because everybody who has laser surgery is very happy. They come in, it's the happiest part of our practice, laser patients. It's almost guaranteed that they will be spectacle independent. It's a big paradigm change for them in their everyday life. And let's go see how we can do this. So this is some of the history of doing customized ablations and why topography guided was designed back in the early 2000s. It first became CE-marked in 2003. We had the privilege in Athens to be able to work with topography guided. It was designed to treat eyes such as this. This is a small broadbeam laser ablation, and you can guarantee that patients with this small optical zone in the position of those of you in the back of the room would have problems with halos, because the pupil dilates past that 4mm optical zone, and then you have problems at night. Nevertheless, the majority of those patients were happy because they were spectacle independent. But the procedure was not at the level that it is today. So we were able, with topo-guided at the time, to enlarge the optical zone. We were able to, this is a contact lens, and it comes back to what I mentioned before, a contact lens related scar in the cornea. So an infection from a contact lens that was treated and left the cornea very significantly irregular. The scar has flattened the cornea has thickened superior to the scar, and it almost looks like an upside down keratoconus eye. So for someone who's contact lens intolerant, this means a cornea transplant. You have to call David Gunn, send him to his office, and do a cornea transplant. There's no other way around it. So with topography guided at the time, we're able to laser this eye, reshape it, and be able to make this patient functional again with their own cornea. This was huge back then. This is a little bit of history. And we were the first team that dared to use this somewhere that everybody else thought we would never be using laser, in keratonic eyes. And this is the story of someone getting cross-linked, and this is one of our patients, the first published case. It took me 3 years to publish this case. Every journal in the English literature rejected this for year after year after year. So this is after cross-linking, before and after, and this patient was still contact lens intolerant, so he said, "Doctor, I thank you very much for your service. I know that the topographies look better. I can't wear contact lenses. I need to have a cornea transplant." So that's where the decision was made to use this technology and reshape the cornea. As you can see here, this is still a very regular cornea, but with a soft lens, the patient was able to function. And this was a big green light for us to start working with these very irregular corneas and customized ablations to be able to reshape the cornea in the context that I'm contact lens intolerant, in the context that I'm keeping my own cornea. And this comes from a cornea transplant surgeon. I've done about 3,000 grafts, and I will tell you, and I tell the same thing to my patients, the best transplant is the one you've never had to have done. And this is the truth. So let's go and see some more data. Wavefront was a big, big thing back in the early 2000s. I remember the term eagle eye, eagle vision, and the promise that we were using this astronomy technology now able to be transformed through the laser and treat higher aberrations. Why was it very popular at the time? Because the ablations we had were at that level of very narrow ablations, very significant spherical aberration, and a lot of problems with mesopic and scotopic vision. So back then, Wavefront was a promise to improve that, and in a way it did. The problem with Wavefront is a dynamic measurement, and this is measurement of several eyes through time. You can see that which Wavefront should I pick to treat on any of these patients. It changes with accommodation, with lighting conditions. And Wavelight came and then departed, as we have seen many things in ophthalmology come and go. But we've learned a lot of things from Wavelight technology. We've learned that we can improve our lasers. We can have laser treatments that do not induce such high spherical aberration, thus have better vision in mesopic and scotopic conditions, and so on and so forth. So let's go now on why, in my opinion, what we're talking about here is important. This is a great place, we're having a great dinner, great company, but all this makes sense if we want to pursue human vision becoming better, because we said that it's almost a token that we can offer spectacle independence. And this is an example that if you go back to your office and you study some of the laser patients that you've done, it doesn't take many, 2 or 3, you will find one patient that your subjective refraction at the hands of the best person that can do subjective refractions will be at a cylinder axis, and this is the cylinder axis on this case, that's different than the topographic cylinder. So we can all agree that this eye has the size of an eye of a patient. So this patient has astigmatism in one of their eyes that's with the rule. Do we all agree on that? But the refraction, as an oxymoron, is way away from that axis in the amount. So the refraction is half a doctor at 45 degrees. The topographer reads 1.11 at 180 degrees. Now this is a surface topographer, this is a reflection topographer. So the next question here for cornea keen people is, okay, let's see the total cornea power. So let's assume we have a pendicam here and the total cornea power is the same. So there's nothing funny going on in the back of the cornea. He wasn't born or she wasn't born with forceps. There's not a split decimates in the back that will explain this difference between the surface cornea power in astigmatism and the refraction. Why is it that this patient is refracting at a different axis and with a different amount of cylinder? Who wants to answer that question? No, not from this table.
Internal seal.
That's a good point. That's a very popular subject. Maybe accommodative sill, or some people have advocated that there may be some cylinder on the macula that I maybe not perfectly built by nature. And that's definitely a valid point. We'll count that as a plus. I will draw your attention, and this is what we theorized through the years, to the angle cap of this patient. So if we look at the topographer, the center of the mires, the reflection mires, are on the vertex of the cornea. So theoretically, the center of these circles that we're seeing on the reflection of the cornea are right along the visual axis of the patient. The geometric center of that cornea is that little dot next to the center of the circles. So the difference between the two is the angle kappa, which is on your topographer noted here in microns. The x-axis here, so this is the x-axis, and the y-axis is the vertical axis. So this, please.
Another possibility is that when you look at the ablation profile, you pick over on the right-hand side there up the top, that the coma, the triple that you have there, the horizontal and the vertical, can balance each other out, and you're left with just that oblique coma.
You gave it away.
Yeah.
Hey. So that's absolutely correct. So this regular cylinder with this angle kappa for this patient, and you have many patients in your practice like this one, acts as a prism. So imagine I have regular cylinder. We all consider this cylinder as being naive, we can treat with classes, but in reality, if there's angle kappa, this cylinder is decentered to the visual axis of the patient and acts as a prism. And this is what the topographer is trying to do here, and very well said, is trying to correct this oblique coma. So this looks like a trifold, but it's hotter in this area. It's less hot here, so it's trying to correct an oblique coma And the patient is trying to correct that by choosing arbitrary cylinder here to correct that coma. Now, if you do a waveform-optimized laser procedure or a SMILE procedure, and SMILE currently is a fantastic procedure, you will carry on this problem from pre-op to post-op, no harm done. So you have a 20/20 patient here under your refraction. You do a waveform-guided procedure, a waveform-optimized procedure, or a SMILE procedure. You carry this default coma post-op. The patient is 20/20 happy, everything's perfect. So why are we talking about here? Why are we making a point out of this? Because if you correct this, you will reshape this cornea to be centered to the visual axis of the patient and not the geometrical center of the cornea. So you will improve the optics of that eye. The eyes are not built to have a perfect cornea lined up with the macula. There is some deviation on almost every eye. 80% of the people in here, I guarantee you, if we map them on the device, unfortunately we're going to bring one here today, we will find that they have significant angle cap. So what if I told you that you have laser surgery, and as a freebie, we line up your cornea perfectly to your visual axis? There's a few things that we have to consider here is that the visual axis is not always the same for patients. There's a theory that it may change with time, it may change between photopic and scotopic conditions, so I know there's some criticism there, but let me go with my story here, that we have the ability of doing this. And we brought this argument up when we first started doing topography guided back in 2008, 2009 on our routine myopic patients, because we saw that we were able in these patients to improve the optics of the cornea. And of course everybody thought I was mad, until the topo-guided platform by Alcon became FDA approved. And what happened then in 2013 is that nobody, and I dare you to look at the FDA data, they're public data, you can enter the FDA website even from here, and all the FDA trials are available. If you compare the topography guided data with the Alcon device to any other FDA approved device, up till today, the data are better. And the reason the data are better is because the topographer improved the cornea symmetry to the visual axis of the patient. It's that simple. Now, what's the problem here? Is that everybody used topography guided with the subjective manifest refraction. So if the patients had significant angle kappa, you treated the wrong cylinder. Because if you reshape the cornea, then the cylinder that you should treat should be the cylinder that the cornea had beforehand. And this is how we came up with the TMR concept. This is a similar example, again showing does not look that regular, but this is regular astigmatism seen with significant angle kappa on the y-axis. So the topographer is looking this cornea from under, kind of looking the rest of the world from Australia. So we have this kind of keratoconus-like picture, but the topographer is going to fix that because it does read it, and it gives you this regular ablation. And again, there's a big difference between the axis of the subjective refraction and the topographic refraction. So we saw this concept and we dared to use the raw topography data for axis and amount of astigmatism, and we call this TMR, topography modified refraction. And this is different than Noah Alpin's, who's a native Australian, theory of vector astigmatism, meaning use the subjective and the topographic and use the medium between the two, because you're reshaping the cornea with a topography guided treatment. And the data that we published there are similar to the data that Dr. Bala presented here today. Most eyes gained lines of vision. And again, people thought I was mad, because everybody said, why should we do all this complicated thing? And why is it that it works? And why is it that it doesn't work? So now you're starting to understand what my interest is in Wavelight Plus. And why is it that Wavelight Plus is vindicating all these data that we have published in the past? And this is showing that the topography modified treated eyes with topography guided Contura gave lines of vision gained. And there's no secret here. The lines of vision gained were because the cornea was reshaped to be symmetric to the visual axis of the patient. And now we're changing a paradigm. When I trained in New York, in Boston, we thought that human vision can reach 2020, maybe 2016. 3 years ago, we changed all the optotypes in my office, 2 optotypes that go all the way down to 2010. Because now we're measuring patients with vision in 2010. And this is a new thing, for me at least. So let's go to ray tracing, and let's see how all this clicks in with ray tracing and Wavelight Plus. Ray tracing is basically doing all this work that we talked about before automatically. So you have one device. Before, we were taking wavefront measurements, we were taking topography measurements, and topography modified is something you have to go into the software and do. And of course, when a surgeon is playing around with the software, there's always an open door for mistake, and you can treat the wrong numbers. So here we have the software, as Chandra mentioned, and our esteemed speakers will talk about today, that through one device, it takes a pentacam basically measurement. So this is the pentacam measurement here, high resolution pentacam. And this is basically a modified Oculus. I saw it on the floor in your meeting today. It's a Pentacam HR Wave AXL. So it's taken by Wavelight Alcon, and it's turned from a diagnostic tool into a treatment tool. So the data from this device, which is the Pentacam map seen here, and the wavefront map using Hartmann-Shack seen here, and the interferometry data is seen here, and the device has a way of establishing that these measurements are accurate enough and stable enough. Otherwise, if they don't check, if they're not accurate enough, then they will not proceed. So these data are used to go into a calculation that it is calculating lower aberration, so myopia and astigmatism. And we all can do that, but also higher aberrations. And also tilt between the cornea and the natural lens of the eye. And that's the concept between ray tracing. So you're measuring through the ray tracing of the 2000 rays from the pentacam to the lens, and 2000 rays from the wavefront measurement from the retina to the lens, and tilt between the two optical systems, the lens and the cornea, through a model that's not the Goldstern eye, but it's, as Professor Ballard mentioned, an avatar eye constructed by the software for each individual patient, for each individual eye. So let's see how this works in practice. This is a patient, and for me, every patient that walks in the office needs to have an epithelial map to prove to me that this eye is naive as far as aerobic, contact lens, whatever. Normal topography, this is Contura, topography guided, this is Wavelight Plus. What's the difference between the two? The difference is this will also treat tilt between the cornea and the human lens. So it takes it even a step further, because the cornea is an optical device, so to speak, and the lens don't necessarily perfectly align to each other. So there may be a tilt between them that can be corrected by this technology. So this is the measurement before on a patient, and this is proof of concept. This is measuring the same patient a month later with the same device. And what are we seeing? We're seeing a perfect ablation, perfectly centered. We're seeing numbers that are essentially zero, and we're seeing a perfect wavefront. And this is very tough to do. You can have 20/20 with many technologies, with SMILE, with any laser in the world, and I've used them all. IVIS, Schwinn, Vizix, but you cannot have wavefront maps like this. And this is where Wavelight Plus kicks in. And it makes me wonder, why is it that Alcon has taken so many years to launch this in this beautiful country? We've been using this technology since 2019, where it became CE mark. But Alcon is, as you all know, the most serious company out there. It wants to work out all the kinks and make sure that this is well studied, and it has been well studied. There's over 10 papers in the literature. I think Chandra has the most cases in the world. But there's a lot of clinical data out there showing that this is unparalleled because you can achieve these data by working with your laser and doing a lot of labor, but this is done automatically. You're not using an algorithm, you're not changing the numbers, you can validate the data on your lower abrasions, your higher abrasions. It is your choice to proceed with this treatment that, as proof of concept, does give you eyes that see better than with any other laser platform. Did I convince you? Maybe? Maybe not? Okay. Now, this is a case that I wouldn't do laser on a subjective refraction anyway, because the epithelium is a mess. So remember, one of the basic things of achieving excellence is you need to be a good diagnostic physician first. So that's why I use epithelial mapping, and we published over 50 papers on how epithelial mapping is very important to diagnose dry eye, post-cataract, post-DSEC, post-PK, post-laser refractive surgery, and these data of epithelial healing are also incorporated in the Wavelight Plus platform. So this patient, I would first want to treat the external disease, the dry eye, before I offer laser surgery, and if it doesn't improve, then I will go to a lens-based procedure on a patient like this. I will not treat this patient with laser. These are the data of the multi-center study, 2 centers in Germany, us from Athens, and I think it was Chandra from Australia that showed now 4 centers separate from each other, different surgeons, different diagnostic refraction mechanism, same data. That shows that this vehicle drives well in Australia. In Athens, Greece, we have the worst streets you've ever seen. Germany, and it is proof of concept that it's a stable technology there to stay. And the data are published literature. I won't bore you with the numbers. We've used this technology also in PRK. Not every eye is a LASIK candidate eye. And I use the EBK device to make a very small epithelial defect. We call it a mini PRK. But these cases here were treated with the RayTracing technology, the Wavelight Plus technology. I don't know if I'm allowed to present this here today, but anyway, I'm showing it to you anyway to show you that this is a technology that changes the paradigm in laser refractive surgery to begin with. So a small epithelial removal to have fast healing. These eyes heal within 2 or 3 days, as you can see here. And RayTracing offers us, like in all other concepts in LASIK, eyes that gain almost 90% 1 line of vision, almost 40% 2 lines of vision when compared to pre-op. This is just basically showing you the epithelial healing between LASIK and on the left column. My laser pointer is dead. Oh, there it is. I don't think it's reflecting out there, or I'm not seeing the reflection. The left column is our LASIK, 1 eye, LASIK eye. The right column is the contralateral eye of the same patient treated with SMILE. This is a study we published. We did back in 2015 with the older VisionMax device, and we showed that between the 2 entities, they're more similar than dissimilar. LASIK and SMILE have a different epithelial healing profile, but they're more similar than dissimilar, so it's the curvature change that basically creates dry eye and laser vision correction. And this is our RayTracing experience when we looked at 2-year data in our center in Athens, which mirrored the data we saw before. This is the contrastivity slide that I used in the beginning. The post-op contrastivity is better than the pre-op as an average in the patients. The post-op astigmatism is better than the pre-op astigmatism in all cases. They're very stable, and even at 2 years out. And if you use the National Institute Visual Function questionnaire, which we chose 6 of the key questions: night driving, visual disturbances, compare contact lenses versus post-surgery. The numbers show that functionally, in this psychometric measurement, patients did better after procedure than before. So, for me, I'm convinced. I use RayTracing on every patient since we got the device in 2019. The question is that you should endeavor into this if you're seeking for your patients something that's beyond spectacle dependent. And it is a technology that, if anything, teaches you a lot on how human eye works and how our capability of changing that has changed through the years. And this is a good year and a bad year in terms of that I had the chance of having lunch with my mentor in Boston in April. Klaus Lohmann is the father of cornea surgery. The older people in the group probably know of him or know somebody who's trained with him. I had the privilege of training with him and training with, before that, my mentors were trainees of Klaus's. Klaus passed away last week at the age of 102. And at our lunch meeting in Boston, we were talking about research projects that he was involved in. So I think it's a man we should more celebrate than be sad of losing. And I dedicate this talk to him and his legacy. Thanks so much for your attention. Thanks for having me.
For John. The questions are coming through thick and fast, but just a reminder, if you're going to put in those questions on your sliding up, on the QR code, or on